Etiology. All true strictures are either inflammatory or traumatic, and almost all inflammatory strictures are gonorrheal. By far, the greater number of strictures are gonorrheal. Thus, out of 220 cases studied by Thompson, 164, 75%, owed their origin to gonorrhea, while Martin found among 219 cases 187 gonorrheal strictures, 85%. My office casebooks record 583 gonorrheal to 43 traumatic strictures. The causes of gonorrheal stricture are, however, many. The inflammation itself usually causes the stricture, but it is difficult to estimate what proportion of strictures is due to breaking a cordie, to a false motion in coitus causing a tear in the inflamed mucous membrane, to the ill-advised use of caustic injections for the purpose of aborting the attack, or to the injudicious use of instruments in the urethra before the attack has subsided. Such strictures are properly traumatic, since trauma of the same kind, but greater in degree, may cause stricture when the mucous membrane is not inflamed, and the gonorrhea thus only plays the role of a predisposing cause. There is a small class of intermediate cases in which the stricture is neither absolutely inflammatory nor traumatic. To this class belong strictures caused by urethral chancres and ulcerations, or loss of substance from periurethritis, etc. Footnote: 10 cases of diffuse urethral syphiloma have been reported. The causes of traumatic stricture vary widely. The penile portion of the urethra may be divided by knife or bullet, or torn by bending the erect penis, by a false motion in coitus, or by breaking a cordie. The bulb is the portion usually affected by trauma from within, by ulceration from stone, foreign body, or retained catheter, or by the sharp point of a blundering instrument. The prostatic urethra is said to become strictured when torn by disruption of the pelvis. But of all traumatic strictures, recognizable as such, stricture of the membranous urethra is the most frequent. The stricture is caused by a crushing force applied to the perineum, which brings the urethra sharply into contact with the subpubic ligament, crushing it beneath the sharp edge of this structure or tearing away from it in front. The injuries which have caused traumatic stricture in the perineum, with or without a penetrating wound, are innumerable. They may be summarized in the term straddle injuries. They may be overlooked by the patient if they do not give rise to immediate hemorrhage or retention. Yet in after years, symptoms of stricture come on, and the canal is found tightly contracted at its membranous portion. Pathogenesis. The most notable modern theories upon the formation of stricture are the theory of Finger and the Guillain school and the theory of Guillard. The Finger-Guillain theory makes stricture the result of chronic urethritis. According to these authors, chronic urethritis is essentially a sclerotic process characterized by deposits of cicatricial tissue in the submucosa and even in the corpus spongiosum. This fact is illustrated by numerous pathological findings that would prove its truth were it not contradicted by the notorious clinical facts. For although, as we have seen, acute urethritis is an exudative process that does tend to pass into a chronic sclerotic stage, the essential cause of the exudation is the acuteness of the attack and the extent of exudation, and subsequent cicatrization is proportional rather to the acuteness of the attack than to its duration. Hence, although stricture is always accompanied by chronic anterior urethritis, chronic anterior urethritis may exist for years without inducing stricture. We therefore accept Guillard's theory that stricture depends upon the virulence of the urethral inflammation. The more severe the initial attack, the more intense the cordie, the more frequent and violent the relapses, and the longer the gonococcus can be found in the discharge, the greater is the probability of stricture. He believes that in a mild chronic stage, the urethral inflammation is neither deep-seated nor productive of any permanent lesion, while the acute inflammation, with its involvement of the lacunae and glands, its circumscribed or diffused areas of periurethritis, is the inflammation calculated to leave behind permanent scars in and beneath the mucous membrane. In the etiology of traumatic stricture, urinary infiltration must play some part. It is true, severe contusion and laceration of the urethral wall are ample causes for stricture, but it is incredible that the muscular disturbance of urination and the distension of the wound with a fluid containing urinary salts and urethral bacteria should cause no increase in the inflammatory reaction. The admirable results obtained by simple perineal section and diversion of the stream of urine from the wound confirm this belief. In this connection, the time of occurrence of stricture after gonorrhea and injury is of interest. Of the 164 cases of stricture following gonorrhea, tabulated by Thompson, in 10, symptoms appeared immediately after or during the attack, 71 within 1 year, 41 between 3 and 4 years, 22 between 7 and 8 years, 20 between 8 and 25 years. Hill makes the length of the period between the cause and the first symptoms of stricture noticed. After gonorrhea, shortest period 2 years, longest 13 years. After urethral chancre, shortest period 10 months, longest 3 years. After injury, shortest period 4 months, longest 18 months. I found among 212 cases of gonorrheal stricture, 121 cases within the first year, 65 distributed between the 2nd and 10th years, and 26 after the 10th year. On the other hand, I have seen an impassable stricture in the perineum 6 weeks after a severe injury, and Guillain has met a stricture which only admitted a 16 French sound 2 weeks after injury, and another which would not admit a 12 French after 6 weeks. The deductions from the above statistics, confirmed by daily observation, are that the symptoms of stricture appear earlier after traumatism than after gonorrhea, the date of their appearance being measurably proportionate to the extent of the injury, and that the greatest divergence is noticeable after gonorrhea. It is totally exceptional, however, for symptoms of organic stricture to come on immediately after or during the attack of gonorrhea, as Thompson states occurred in 10 of his cases, unless stricture existed previous to the attack, unnoticed by the patient.